Good afternoon. I'm Mary Jane Marchisotto, and it's my pleasure working closely with colleagues at the Mary H. Weiser Food Allergy Center for the past decade or so. Today, I'm pleased to partner with Dr. Linda Herbert to present on using food allergy patient voices to guide research about mental health needs, part two. Part two, because we did part one of this talk about a year ago when we presented some phase one research results from a study that we're working on together. So now let me introduce Linda, and I apologize while I read from her rather extensive resume. Linda completed her PhD in Human Services Psychology from the University of Maryland, Baltimore in 2011, including a psychology internship at Nationwide Children's Hospital. She is a recently promoted associate professor of psychology and behavioral health at Children's National and an associate professor in the Department of Pediatrics at George Washington University School of Medicine. Dr. Herbert is the Director of Psychology Research and Clinical Services for the Division of Allergy and Immunology at Children's National, a program which she started in 2013 and which represented at that time one of the few such programs in the country. In fact, I'd say in the world. Linda is an NIH-funded clinical researcher whose research interests include pediatric allergic diseases and acute and long-haul COVID-19. She is the principal investigator for a recently awarded NIAID-funded R01 to conduct a clinical trial of a behavioral intervention for early adolescents with food allergy, and a co-investigator on a multi-site prospective longitudinal cohort to systematically investigate disparities among Black, Hispanic, and white children in food allergy, clinical and psychological outcomes, food allergy phenotypes and endotypes, and food allergy management practices. Linda is a consultant on a PCORI grant awarded to food allergy research and education, designed to increase diverse engagement in food allergy research. Linda is also a co-investigator on an NIH-funded study regarding the trajectory of COVID-19 infection on pediatric patients. She's authored over 50 publications and is a member of the editorial board for the Journal of Pediatric Psychology. Linda presents her research pediatric psychology and food allergy and immunology, and was awarded the Heritage Lectureship by the American Academy of Allergy, Asthma and Immunology in 2018. She regularly engages in advocacy work with national food allergy organizations such as FARE, the Food Allergy and Anaphylaxis Connection Team, FACT, and the Asthma and Allergy Network, along with this, her second webinar with us at the Mary Weiser Center. She's also a board member of the Maryland Pediatric Association. And beyond all of that, maybe what she would say, a devoted Nationals fan and mother to the almost 6-year-old Natalie. Okay, now I need a glass of water after that extensive introduction.
Then I will slightly correct you, Orioles fan.
It's the Orioles. I knew as soon as I said Nationals, I said it's the Orioles, idiot.
I do love the Nats too, because I'm in DC, but Orioles through and through for me.
Yeah, sorry. Okay, so what we're going to talk today about is work that really dates back to a grant that Jim Baker and I wrote about 8 years ago with PCORI. When we formed a group of stakeholders to systematically identify food allergy research priorities from a patient perspective. One of the 5 priority areas was mental health. And the team took a deep dive into mental health issues, which really kickstarted some publications, some research efforts. And this, I will tell you, about 80% of the folks who worked the researchers who worked on that PCORI grant are involved with the GAP study. And we added some non-US friends to that research team, as you'll see a little bit later. So we've been able to take work that was initially published in the United States and take it global, which is a theme that we've done successfully, or the patient groups have done successfully over time. And what Linda's going to talk about is the history of that research project and how we're going about, she and others are going about doing the creation of an intervention. By way of background, Linda and others have shown that food allergy patients and caregivers of children with food allergy experience decreased quality of life due to the anxiety of managing food allergy on a daily basis, and that the access to mental health services to address these concerns, which may be crucial in supporting families, is sorely lacking. Before we begin, before Linda takes us through the journey of where we are in the research, I want to step back for a second and ask Linda, what is it that drove you to think about food allergy and focusing on patient-centered outcomes?
Well, thanks, Mary Jane, for the introduction. And I love this question. So I was realizing while I was at the Academy meeting over the last couple of weeks that I've now been in the allergy space for about 20 years. So I've been reflecting a lot on like, how did I get here and why is this my passion project? And a lot of it really comes down to I've always had this interest in child and family health and the way that food, like the cultural experience of meals and gathering and traditions has been a significant piece of family life. And when I was an undergraduate at UMBC, I had the opportunity to study under a psychologist mentor who was at the time working with an asthma and allergist at the University of Maryland Medical Center. And this allergist was saying to us, like, I'm seeing something really interesting going on with our allergy patients. Parents are reporting a lot of stress and anxiety about this. And so we kind of got in on the ground, like understanding the quality of life and the impact that managing food allergy can have on families. And as I saw, like every meal, every snack, like every interaction when parents are trying to work through play dates and school interactions, all of this is so shaped and affected by having to avoid allergens and be prepared for emergency management. And I saw that this was an area where there wasn't much done yet. And I felt like, I had this responsibility to kind of dive into this and to care about these families. And I love it. Like, it's really something that's been incredibly rewarding to be able to help grow this space and to help families, because again, we eat many times a day. And if you can have a positive impact on a family around food allergy management, that can transform things in their life. And so I've fallen in love with it for that reason.
Well, the field's lucky to have you. It has been, just an incredible rate of change in the research and in the findings and in the understanding and the collaboration. And actually, that's a theme we're going to come back to a little bit later when we talk about your research and where you've come to. So we're going to start with the conclusions of where we are in phase 2, and then Linda's going to explain how we got to where we are. She's going to talk about the results on a phase 2 study, and these are initial preliminary results of interviews of adults in the UK about food allergy. And 3 main themes are coming out: their experience with healthcare providers and systems, society in general, and unmet needs. In a second, Linda's going to talk about that work, and which was presented in an abstract, a poster by Linda and me last week at the Quad AI meeting. The patients described not being taken seriously by their primary care physician, anxieties being minimized or dismissed, that there was perceived lack of knowledge about food allergy from the medical profession and the general public. Patients struggled to access information about food allergy and much less psychological support. And they felt very strongly that a holistic approach to support their needs was needed through more readily available resources. So this is a picture of Linda and me with the poster in front of our poster. Unfortunately, you can't really see it on the top, so I'm going to read the title, which is, "Here's your EpiPen. Good luck to you. The healthcare experiences and psychological support needs of adults living with food allergy in the United Kingdom." Kind of says it all in terms of what it is. Here's your Epi, see ya. And that's a direct quote. So, Linda?
Yeah.
hit the page. Tell us how we got there.
Yes. So I think one of the things that has always drawn Mary Jane and I to work together is this emphasis on stakeholder perspectives and listening to patients and families about what it is that they need. And a while back, when we first got interested in this space, I was working with Mary Jane on a PCORI award, for which we conducted a series of focus groups from stakeholders all across the United States. And what we were hearing from them was about their priorities for research and their priorities in the field. And mental health was really coming across as something enormous that was lacking, that was missing, that they thought should be a priority. So from there, we decided, let's find out a little bit more about what is happening within these stellar food allergy clinics throughout the United States. So we did an assessment that looked at whether or not individual clinics had mental health support, when they were offering that support, what they thought their needs were. And we found that very few clinics had a psychologist or mental health professional embedded in their clinics. Very few had access, even in the community, to individuals that had food allergy expertise. And so we said to ourselves, all right, well, we know that this isn't being offered in clinic. What are our patients saying? Are they saying that they're having challenges accessing mental health services or not? Are they saying that they need this or not? So we then created a survey that was implemented in the United States, asking these questions, and found that families were saying, yes, we're having concerns. We feel that we need more support. And Mary Jane was brilliant and said, I bet that this is happening internationally too. And she had this inspiration to bring this global. So we have been working with a wonderful global team ever since to take the survey that was initially done in the United States and implement it throughout the world. And that's really what we're talking about in this initial study period, this GAP study.
Actually, you know what I just want to add to that, Linda, is we involved not only, a global team of investigators, but we also brought in all the patient groups. And it was truly participatory research by among the patients. All too often, researchers will access patient groups, and it's really, give me your Rolodex of names, and I'm going to go talk to them. We didn't do that. The patient groups looked at the survey, opined on the survey, made suggestions to the survey questions, have been involved in every stage of our research. And when the data becomes available, we owe it back to them. We've already committed to give the data. What does it mean for their countries? Because we had, and Linda will show you in a couple of minutes, some really strong participation from around the world.
Mm-hmm. And it's that type of iterative approach that I think is incredibly valuable. Like the scientific method that gets me jazzed is working with families to develop a research question, working with them to develop then some methodology, implementing the research with a group of experts, and then going back to patients and families and say, this is what we found. Now, how can we advocate for better healthcare for you? How can we take what we've learned to put in place the things that you need? So so this GAP study is the result of some of this initial work. And we have presented some of this before on phase 1. So we're just going to quickly go through that so we can get to phase 2 and then some other examples of intervention work. So the GAP study is the Global Access to Psychological Services for Food Allergy study. Our purpose is to be a multinational study that assesses access to and uptake of psychological services, as well as exploring patient needs, and ultimately then to do something with this, to develop online materials that will help patients and families, because I think it's incumbent on us that when we work with these patients, when we ask them what they need, we then have to go back and do something about it. And we have proposed 3 phases. The first was to do this online survey across multiple continents, multiple countries about needs and uptake of psychological services, to then do some in-depth interviews and a follow-up survey, and then develop and pilot these online resources. So let's go through this phase 1 briefly. Our methods for this first phase were to develop these questionnaires, as Mary Jane said, in concert with patient organizations. And then we use the patient organizations as well as social media and online survey panels to recruit participants. And one of the things that I love is that we were able to offer this survey in 6 different languages. So English, French, notably both France and Canadian vernacular, German, Spanish, Portuguese, both referencing Spain and Brazil, and Italian. And the questions were primarily about any type of psychological distress related to food allergy that we're experience with mental health screening, with mental health appointments related to food allergy, and barriers to seeking care. And we asked not only parents of children that have food allergy, but also patients who are adults with food allergy. And then if they were old enough, kids as well were able to give their own perceptions of their experiences. And we have touched on these results before, so I'll just kind of briefly recap these. Here, what you see with these bar graphs is that we had representation across many countries. We had over 1,300 participants. And as you can see here, there are many individuals who are reporting psychological distress related to food allergy, ranging from this 50 all the way up to almost 100% of families in Australia and Brazil. When we look at whether or not folks have been screened for food allergy related distress, we see that the numbers are far lower, with really, the highest number of patients being screened in Germany at 52%. You'll note that here, in the far left, we have Brazil and Australia who are reporting they're not being screened at all, yet they were some of the ones reporting some of the highest rates of distress. And I know, Mary Jane, you have found this to be really compelling as we've looked at this.
Yeah, I mean, that barbell is just, I went back and looked at it like 3 times and say, how could that possibly be?
But yeah, this is something that our families are telling us.
Mhm.
And then we also have asked whether or not they had visited or attended an appointment with a mental health professional strictly due to food allergy related concerns. And we see that there are many individuals who are saying that they have. But you'll note that, this is far less than those who are saying that they've experienced psychological distress. So there's a lot here that has room for growth, areas for us to be addressing. And this beautiful heat map, I'll kind of orient this to you briefly. We have colors in red to colors in green, and the ones that are kind of these red orange, these are the ones that are like popping up the most. These are the barriers that we're hearing about more than any other. And what you see is that almost every single country, families are saying that cost is the primary barrier to mental health services. Then there's also the concern about practitioners not being available, about doctors not providing referrals, about finding childcare. So many concerns, cross countries about what to do, with cost being a big one. And this is important for us to hear because as we think about how to develop an intervention, we need to be thinking about how do we do this in a way that is accessible at a low cost to families, that is something that's available maybe irrespective of whether or not there are providers available in their area that can offer it, and something that you can do even if you can't find childcare. And so as we've thought about this, like the online format seems to be one that would be beneficial.
Yep, it's cost and access. That's it.
Yes, which is not surprising, right? Like that's we hear about a lot of healthcare, but we need data. We need data to show and to guide us. So this is why we ask these things.
Yeah, I mean, that's just the point. It's a lot of these conclusions are not shocking at all. I mean, it's like, yeah, common sense, but in the absence of data, nobody believes you.
Exactly. And then if you just look here to see, what type of support are individuals receiving from mental health professionals, it's a lot of cognitive behavioral therapy, it's general daily family struggles with food allergy. Some folks are getting coaching, some are getting help with consultations with the school. I think that this trauma therapy bar is really interesting because we are starting to understand more about what families experience after an allergic reaction. Some are reporting symptoms that sound very much like an acute stress disorder or post-traumatic stress disorder. So it's a lot of things that families are wanting to get help with. So just to kind of conclude from this phase 1, we see that there are across countries, large proportions of caregivers reporting food allergy related psychological distress. yet many don't have access, and they need the support. There is some variability with respect to access and uptake of services across countries, but overall, you saw those bar graphs. They're very, very high numbers. Cost is a huge barrier. And, as I kind of alluded to, an easily accessible, low cost or free resource is really needed to help these families. So that was phase one. We then moved to phase two, where we're conducting more in-depth interviews and follow-up surveys. And so my colleagues in the UK are spearheading a lot of these interviews with families. And so that phase one was what we call quantitative data, where we have surveys, we gather frequencies and means and standard deviations and things like that to give us a nice overview. But then the qualitative piece, these interviews, this is where we can really get the depth, where we can find out, like, okay, what did happen when you tried to access care? And what was that like? And that is what Mary Jane was kind of alluding to with our findings earlier. So far, and this is ongoing, but so far I can tell you about what it is that we presented at Quad AI last week. We had 23 adults who had food allergies. So these are not caregivers of kids with food allergy. These are adults themselves. And they completed a questionnaire about food allergy. They completed a consent, and then they were interviewed online by research assistants using a semi-structured interview guide. So everybody has kind of the same basic questions that we're asking, but in a qualitative methodology, you then kind of dive in further and take the lead of where the family is taking you, so you can get even more beautiful, rich data. So these interviews then were asking about the impact of food allergy on their lives and experiences with healthcare services and psychological support. When you do qualitative work, everything is audio recorded and then transcribed, and then there's a really lengthy process that goes about to code these things. So ultimately, what you develop are themes and codes that are allowing you to get kind of the gestalt of what all the families are saying. So Mary Jane gave us the wonderful kind of heads up as to what we found on this poster that you saw. Really, there were these three main themes that were being encompassed: experiences with healthcare professionals and systems, society, and unmet needs. And this also might not surprise you, but participants were saying that they weren't really being taken seriously by primary care physicians when they were reporting stress, when they were reporting distress, that it was minimized, that it was dismissed by others. That there was this lack of knowledge about food allergy from the medical profession in general and from the general public and food businesses. And none of this is very surprising. Like I hear every time there's a movie or a TV show that uses food allergy as a joke or as like a plot point, like you realize how much this can be minimized and dismissed by others as being something that's really hard and challenging. And that's just one small area of it. And then not only were they kind of being dismissed or was this being minimized, but there was a struggle to access information about how to get psychological support and about food allergies. So they were concluding that this holistic approach is needed. And here, it's always helpful, I think, to hear things in patients' own voices. So here, we just copied over some direct quotes, and I'll read them out loud to you, but it's things like this. In terms of any emotional support, there wasn't anything at all. And if anything, I felt stupid, like I was wasting their time. And yeah, it was absolutely no help at all. Or as the title of our poster alluded to, it was, you've got anaphylaxis, here's some EpiPen, bye. There was absolutely no support over it. Another said, we cannot guarantee that we won't have cross-contamination. And you're just thinking, well, they're not even going to try. Someone hearing, I don't think they realize that it's deadly. Another, any online support, if that kind existed, would be great. I suppose for me, that would be better for me because my time is limited. And also being able to talk to someone about coping with it, hope to cope with it, living your life would just, I think, be so much better. I'm wondering, Mary Jane, if any of these quotes are, particularly striking to you, if there's anything that you wanted to add as we kind of process and like taking what these families said.
No, I mean, I was just struck at, it was kind of everyday language. Yeah, it's in a very matter of fact. Support, what's that? It's good luck. And it was actually worse than I expected, to be honest. I thought people would have, particularly as adults, would have figured out ways to cope better. and the lack of successful coping is what struck me as I thought about it.
Mm-hmm. Yeah, just highlights the need even more.
Yeah,
really does. So that was our phase 2. We can conclude that adults in the UK who've completed these interviews, they have psychological support needs that aren't being met by healthcare services. And it confirms what we kind of found in that qualitative piece, that easily accessible, low-cost psychological resources are needed to support families. And we need to ensure that the psychological part of this is not dismissed for families.
Yeah, and I would just add that, so an N of 23 is a small number. We have more interviews underway now in the United States, in Canada, all up. I think what we're talking 250 by the fall, and like the online survey, they're done in native languages. Just today, Linda and I were on a call with the group talking about the analysis of the data and being able to do those interpretations and making sure in the verbatim translation that they understand what words mean, because English is different from American, and French is different from Canadian French, and slang and buzzwords, which is it's a whole. For me, it was just thinking about a whole new dimension of what's going to go into this analysis. You did mention that we have research assistants doing these interviews. I think it's important to note that they're trained research assistants. They are also expert in being able to fess out information in an appropriate way, without being biased.
Absolutely. Yeah, and they're all supervised by our members of our psychology team that are part of the GAP study. I'll also point out, so you saw that our quantitative survey had well over 1,300 families, and this N of 23 does sound a bit smaller for qualitative work. I'll just educate folks to know that that actually is a large number for qualitative studies, because we typically interview people until we get to what we call data saturation. So once we kind of get to a point where we're hearing the same themes, where we're hearing the same information, then we know that, we've kind of gotten to that point of data saturation and we don't necessarily need to interview others. What's unique about this study is that we are going to have a very large sample of interviews because we're doing them across so many countries. And really that's pretty unprecedented in some of the work that I've done to have that many. So we're going to have some incredibly rich information. And as Mary Jane alluded to, there's going to be a lot of work on our study personnel's end on figuring out how do we put this all together, because we want to make sure that we're accounting for all these really unique experiences that may exist across countries. So we're excited. We're really excited, and we'll at some point come back, I'm sure, and tell you more about what we have found. So from here, we're going to be moving into phase 3 to develop and pilot this online resource for families, and we're equally excited to start working on that together as well. So it's
a truly global team, just kind of going down. It's US, UK, US, UK, and I should say within the US, it's New York, Maryland, Boston, UK, Atlanta, Illinois, Canada, Manitoba, Canada, California, Italy, and then the 3 are from the UK. So it is, and then the 15 patient organizations that have been very active in this from the 5 different continents, whatever. And as Linda said, hopefully this time next year, or maybe even this fall, we'll have some the next phase of data to be able to present to you.
Yeah, we're very grateful to everyone who's worked on this with us. So that's the direction that we're going, is developing and piloting this online resource, and we can come back to that later.
So, and Linda, here, I mean, what does that mean, an online resource? What might it look like? Maybe you can lead us there and give us some insight.
Sure. So as we think about, what families have been telling us over the years that they need and through the study, like we hear they want information and education about food allergy. They want really assistance increasing their self-efficacy for managing food allergy out in the world, which means that they want to feel better managing anxiety and the uncertainty related to food allergy management. And so that's kind of what guides us as we develop an intervention. The other piece that's guiding us is other evidence-based treatments. So food allergy is not an isolated chronic health concern. There are many other chronic health conditions out there, like type 1 diabetes, like having asthma, many different things that we can be drawing on. And we know that's things like cognitive behavioral therapy, acceptance and commitment therapy. There's various evidence-based treatments that are being used for these other chronic health conditions that apply equally here. So all that being said, what I'm envisioning is that this online tool is going to be including education about food allergy that's very practical, skill building. So how to use epinephrine autoinjectors, how to recognize an allergic reaction, how to know what to do when you do experience one or when your child does experience one, as well as psychoeducation about the psychosocial piece. So what is anxiety? When do we experience anxiety? How do we manage uncertainty? How do we help differentiate between the symptoms of an allergic reaction and anxiety? Because they can seriously overlap in many families. We will probably be talking about avoidance behaviors. So when we feel anxious, we avoid certain situations, which actually then can reinforce feeling anxious and avoiding it because we don't see that we're capable of handling those situations. So in addition to this education about food allergy, psychoeducation about anxiety, we then would be using cognitive behavioral strategies to help families manage that uncertainty. So that could be developing relaxation skills. That could be developing sets of ways to counter some anxious thoughts that come up in the moment. Could be building up assertiveness training skills so that families are able in the moment to say what they need from others to help keep their child or themselves safe. So these are just some things that are like coming up immediately for me that I think about. But what's wonderful is that this GAPS study team includes many psychologists, all of whom will be able to come together and bring our expertise so that we can develop this together.
And now you're going to show us about some research where you've done things like this. So please tell us about your recent grant and how it fits into the bigger picture.
Sure. So as Mary Jane said, in addition to working on the GAPS study, I have my own kind of research program at Children's National in Washington, D.C., where I've been looking to develop a behavioral intervention for adolescents. So we know that adolescents with food allergy are at increased risk for things like allergic reactions and anaphylaxis and not having access to treatment in a timely fashion. So this is concerning to me. And we also know that adolescence is in general just a challenging time when you're figuring out who you are as a person, when you're navigating the world more independently. And so I have really wanted to find a way to support kids as they become independent food allergy managers, to give them that confidence that they can do it, and also to ensure that, that risk of allergic reaction is lower. So there's this beautiful model called the Orbit model of behavioral intervention development in the psychology world, which is a very systematic approach to developing an intervention. I frequently say, and kind of chuckle about this, that my research is slow and methodical, but that makes it evidence-based. And that's how I know that at the end of the day, what I'm giving back to families is something that I can stand behind and that should be working. So what this model—
So when you say, because you've got K and R, and tell people what they stand for, and what's the time lapse that beginning the K to the R to the completion of the R? How much time are you talking about?
Sure. So this is a lot of time. we first kind of start out with a significant clinical question, and that's what you see is this circle all the way on the left, and you see that I have this K23 here. So I saw food allergy is a pretty open space. We need to learn a lot. We can't just dive in and develop an intervention unless we understand more about what kids' needs are. So I was able to get what's called a Career Development Award from NIAID back in 2016 after having applied for it for a couple of times, which allowed me to have a 5-year study where I did quantitative questionnaires with kids, as well as these deep dive qualitative interviews. And all of that allowed me to come up with the different components that would be important for a behavioral intervention for them to support them in their food allergy management. That then led to this box you see in the middle that includes phase 1 design, phase 2 preliminary testing, this arrow that has pilot data. I then spent about a year developing the actual intervention and getting focus groups and showing it to kids, and then trying it out with a very small group of families. And we'll go into this in more detail in some of our other slides. Once I got through all of that and saw like there is reason to believe that this will be helpful for families, I started applying for a different type of grant from NIAID called an R01, which is a large-scale 5-year grant as well that will allow us to do what's called a randomized clinical trial. So we'll be able to recruit a large number of families, randomize them to either get the intervention or usual care, and allow us to compare how they do on a couple of different outcomes like food allergy skills and management and quality of life to see whether or not the intervention has worked in the way we want. So all told, like I started applying for this K23 in 2014, got it in 2016. It was a 5-year study. In 2021, during the pandemic, I was collecting my pilot data and I was applying for this R01. I was fortunate to get it on my second submission, and it was awarded in November 2022, and it's 5 years. So we'll be looking at outcome data in 2027. So what is that, a span of what, 12, 13 years?
15.
Yeah.
So not that I can do quick math, but Linda, question. The trial, I mean, you haven't designed it yet, but how large do you think it might be? Is it going to be at multiple sites?
So it is designed actually, yes. And we'll kind of, in the next couple of slides, we'll build up to that, but I'll give you kind of the end first. So we're enrolling 240 families. They will be randomized into this intervention or usual care. And it's all happening at my hospital. We're recruiting from the patients in our clinic because I'm very dedicated to ensuring that anybody in my research actually looks like the patients in my clinic. I want this to be accessible and relevant to a diverse range of families. So, yeah, we actually are hoping to start recruiting this summer.
Really? Wow, that's great. Yeah. Great.
So let me, I'll kind of tell you a little bit more. So if you can visualize, you know, we started with that K23, the Career Development Award, for which the goals were to evaluate child anxiety related to food allergy, quality of life, and adherence during a 1-year period, and to use qualitative interviews to dive further into factors that affect their food allergy adjustment and adherence. So this is what's called a mixed methods design, both quantitative and qualitative. And over the course of that 5 years, we were able to recruit and enroll 121 parent-child dyads. So both kids and parents would answer questionnaires. Our kids were ages 10 to 14. We really wanted to tap into that pre-adolescent, early adolescent phase. They were about half male. And I was so pleased because my sample really does match our clinic, which has only about 30% white families. We have a lot of Black families, a lot of multiracial families, about 12% Latinx, and had all of our main allergies represented. So this took a lot of time, but we're really happy to build this cohort.
That's very impressive.
So we did a couple of different things, and I want to highlight a couple of different results that we had from this that helped shape this intervention that we're building to. So one is that we pretty quickly realized that there's not a great marker of adherence to food allergy management. Generally speaking, we don't have any biomarkers that tell us if you're avoiding allergens. We can't draw blood and find out like how much you're avoiding your allergens or how frequently you have reactions. Instead, we have to ask people. So we wanted to develop this very comprehensive tool, and we did that, called the Food Allergy Management 24-Hour Recall. And as part of that, we asked kids, what is everything that you did yesterday to manage your food allergy? And that included, you know, how are you making decisions about food safety? And do you have epinephrine with you? And what we found, and what's highlighted here, if you look at the blue bars, is that about 1/3 of the time, kids were relying on past experience with the food to make decisions about safety. And if you ask any allergist, they'll tell you that's not a recommended strategy. You should be looking at food labels every time you eat. You should be asking about ingredients every time you eat. And if you look at these blue bars on the right of this graph, you see that they're least likely to verify their food is safe with a recommended method when they're outside the home. So if they're at a relative's home, a friend's home, or other places. So that was telling us, all right, we really need to focus on some food allergy education and skill building. I don't know if any of this is surprising to you, Mary Jane, but it was actually like way less safety verification compliance than I thought there'd be.
Yeah, you know, but if you think about it, it's like, you know, they're embarrassed to read, they're embarrassed to ask questions.
Mm-hmm. Yeah. So, but here we have some data that show us, yeah, this is what's happening. And then with epinephrine availability, that's the green bars that you see here. We found, you know, it was a little bit more reliably available, which is good. But there was this trend again that if you're outside home at friends' homes or other places or restaurants even, that you don't have it. So what we're taking away from this is that kids have it at home when they're actually least likely to be exposed to an allergen. It's like when they're outside, out and about at school or at restaurants or with friends, that's when they're probably going to be most likely to need epinephrine. So we want to increase their carriage of epinephrine when they leave the home. The other thing is that we have always felt that peers are such a huge part of the food allergy experience, with peers being able to both promote food allergy management if they're supportive, if they help you, if they're not judgmental, and peers also really being able to suppress some behaviors that we think are important. So we also looked at bullying in this sample, and we found that depending on the way you ask about it, there's potentially 17 to 1/3 of kids who are reporting bullying, and that many times parents don't know about it. And what I'll draw your attention to in this figure is that we've broken this down into relational bullying, so like having rumors spread about you, to what we call overt non-physical acts, so being threatened or intimidated. But then also these overt physical acts, which is actually having someone do something to you with an allergen, like touching you with it or having it thrown at you. And so there's a lot of teasing going on. That's the bar that's the furthest.
Yeah, but the teasing is really shocking. Yeah, I mean, that's 1 in 2, right? 50%. Yeah.
And so you have to ask yourself, like, are you going to disclose about your food allergy if you think that this is possible, that someone's going to tease you? So it's a very real concern that we see. The other thing I'll highlight is I want to talk about our qualitative interviews a bit too. So this was a subsample. We interviewed 26 adolescents that mirrored our broader sample, but went until we got to this point of data saturation like we talked about before. And we had a couple themes emerge from these interviews about what their experiences were like. One is that, you know, confirm food allergy is this chronic burden that affects daily life, that there's anxiety about food allergy. Families really want help transitioning management from the parent to the child. This ever-present feeling of needing to be prepared, the need to be advocating frequently for yourself, and this potential impact of social experiences. So we took all of this and went back to our orbit model and got to this pilot phase and said, okay, so we feel based on what we learned from this K23 that there's a couple of components that are going to be really important to include in an intervention. And we're calling this intervention the Food Allergy Mastery Program. So taking a very, health promotion approach as opposed to something's wrong with you, you need help. This is more, we're helping you master this so that you can, grow up and be successful. So the 5 areas that we thought we identified included food allergy education, bolstering stress and anxiety management, assisting parents in transitioning food allergy management responsibility to the youth, teaching executive function and advocacy skills. So executive function is that set of behaviors that are controlled really by the frontal lobe. So planning and organizing and, being able to work on multiple tasks, being able to get started on projects and finish them, all these things that might interfere with carrying epinephrine and avoiding allergens. And then really fostering peer support too, because we really want to know other people that have food allergy.
So Linda, what's the response? Are kids receptive to do this with you? Are parents receptive?
Yeah, they absolutely have been. And we, and actually here, let me show you just a couple examples. And then when we get to the focus group section, I can tell you like the feedback that we got. Okay. So just as an example, in one of our sessions, we talk about navigating social activities, and we talk with kids about this form of off-the-mark thinking. It's a component of cognitive behavioral intervention, where kids are likely to do what's called personalize. And this is something we all do, even as adults. We jump to conclusions or assume that people are saying something or doing something in response to us. And the truth is that people pay much less attention to us than we think that they do. But if we have this perception, if we assume that people are laughing at us because we're different or are looking at us because we're different, we might be less likely to engage in a healthy behavior, like bringing a safe food that you can eat, telling someone about your allergies. So we practice with kids these social situations about what thoughts might go through their mind and what they could be doing to kind of counter that and responding in a more pro-social and healthy way in these situations. Another example has to do with differentiation of anxiety symptoms and allergic reaction symptoms. So we also talk with kids about the overlap between these things. So when I feel anxious, it might be hard for me to think clearly. My heart rate might increase. My breathing rate might increase. I might start trembling and have a stomach ache. And that can be very similar to an allergic reaction. So we teach strategies to kind of manage that anxiety to help kids get to the point that they're able to really differentiate and see, what should I do in the moment? Should I treat this? Should I wait? Should I tell someone? Just helps them to think more clearly and problem solve. So those are just 2 examples. And then Mary Jane, you were asking about like, well, what's the reception to this? So before we even tested it out, we did focus groups. And this is where, we've talked a lot earlier in this talk about getting stakeholders involved. And this is where this comes back into. So we show these things in focus groups to families that are going to be eligible for this. So we showed them all of the content. We talked with them about the telehealth platform we were planning to use. We asked them, what's missing? What do you really like here? What should we spend more time on? What should we spend less time on? Do you think that you would do this? Like if this was offered, is it relevant? Are we being culturally appropriate? And the feedback that we got was that it was appropriate and relevant. They really wanted an emphasis on the social situations and stress and anxiety management. And everybody said, please, please have like a group session so that our kids can connect to other kids.
Really? So they're working with peers and getting accustomed to talking to them about these issues.
Exactly. And to know they're not alone, right?
Yeah, exactly.
Yeah. So then what we did is we said, okay, we have our feedback. We made some changes based on that feedback. And then we recruited an additional small group of families from our clinic. These were different families, not the ones in the focus group. They did baseline and follow-up questionnaires about knowledge and social support and self-efficacy all over Zoom. We ended up doing this with 8 families. They completed all 6 of our sessions. And we had 2 families that had to discontinue, one because they got COVID and another because time was just really challenging. And here's like one of our final slides that just shows you a little bit about what we found from this pilot. So one is that we saw some improvements in food allergy knowledge and saw some areas where we can have, even more that we're injecting into this to improve their knowledge.
Mhm.
We saw some increases in social support, and we also saw some improvements in self-efficacy, in particular about recognizing and treating allergic reactions. And so what you won't see here are a lot of statistical analyses. You really don't do that with a pilot study like this. We're
Right.
not looking,
Right.
we're not looking for that. We're looking at feasibility. We're looking at if we're seeing trends and changes in the way that we think that they should go. So we were really emboldened by this, and this was included in then the grant application for that R01 that I mentioned.
So
Mhm.
so how large do you expect the trial to be? I know you've mentioned it. What was the number?
Yeah, so we're planning to recruit about 240 families
Okay.
over the course of a couple of years. And that's what this R01 is doing now. So we've gone back and we've tweaked like one final time the content for the intervention. We are hiring interventionists who I'm going to be training in food allergy management and implementation of this. We have a biostats person. We have other individuals who are psychologists. We have an allergist on board. So a lot of people who are really providing their expertise in this. And yeah, we just started it, but it just kind of shows you this process of like, how do we go about developing these interventions?
Yeah. So it's, you said it's what, 2013 to 23, essentially. It'd be 10 years in terms of development, getting there. And you said it's a 5-year study. But do you anticipate that you would get interim results, much like we had, very preliminary results in phase 2, that you'll be able to report on?
So what's a little bit different about a clinical trial is that you really don't want to be reporting like outcomes until you really have everything collected. What we will be doing though is like we're going to have a baseline collection phase. And so many times you do look at your baseline characteristics and report on your sample in advance. And then once the intervention is delivered, we are going to be looking at outcomes at 6, 12, and 18 months. So the kind of like rolling results that come out to those time points.
So you'd be able to report on the 6-month data after it's been locked and cleaned and
exactly.
Okay.
Yeah. So it is a process. And again, I say that this research takes a while, but it's really intended to be very evidence-based so that the families that are getting it get the best that they can get.
Yeah. So this may be an unfair question, but it is, as you're thinking about the intervention design, and I know you're beginning to think in conversations with others, are there any broad parameters that you expect might be included in that for the GAP study?
For the GAP study? Yeah. So I think, in many ways, what I've learned from this FAM program informs some of the work that we're doing with GAP. So I think we kind of touched on this a little bit earlier, but addressing self-efficacy, addressing food allergy education, those types of principles that are being applied for teens can also be applied for parents as well. Yeah.
Adults, caregivers, etc.
Yeah.
Okay. So the evidence or the design of the intervention for the GAP study will be based and informed on the successes, the lessons you've learned from other interventions that you've done.
Exactly. As well as what we're learning from the families in the GAP study. So everything will be tailored by what they need as well.
Yeah, it sounds like it sounds like you've had a very productive pandemic period in terms of your publications and successes and promotions and new awards. And I'm hopeful that the next phase of the GAPS gets us there as well. So you've told us about everything that you've been doing. What's out there that you think as a field, we need to do more of? And if you could wave your magic wand and get another, immediately get another R01, what would you want it to be? What would you like? What would you love to see us doing more of?
Yeah. Well, I think really I kind of have two answers to that. The one pertains really to psychological pieces of things. So essentially, we've done a lot of cross-sectional research. We are looking at snapshots of what's happening at various points in people's lives, and we need something that's a lot more longitudinal to help us understand from an early age, what is the experience of food allergy, and how does anxiety develop, and where are the pain points, and where can we be intervening, as opposed to waiting until someone's an adult, waiting till someone's a teen. So I think one thing we need is this longitudinal work that's understanding the development of the psychosocial distress. But I think the other piece, and I'd have to really formulate in my mind what an R1 would look like, is health disparities work. So we are working with families from all over the world now. We're working with families from a variety of socioeconomic experiences in the United States. We are understanding a lot more about the social determinants of health in food allergy. For example, concerns with access to allergen-free food, access to quality care, access to epinephrine autoinjectors, access to enough epinephrine autoinjectors. And so there really needs to be a concerted effort to include families who are of color, families who have lower socioeconomic means in this type of research, to be developing interventions that meet their needs as well, because that's a group that's really been overlooked a lot. And what that means is it takes more than me, and it really takes an examination of the systems of at play in our healthcare system. We might have to be really thinking about big paradigm shifts in order to ensure that all of these families have their needs met.
Well, Linda, this has been terrific. I mean, I've learned a heck of a lot, and I hope our audience, I'm sure our audience will find it as informative as I have. And again, thank you for everything. Thank you for your work. And I look forward to continuing partnership and collaboration with you, and being able to report back to this group in a timely fashion when we have something new to tell them.
Absolutely. And thank you, Mary Jane. I think I've kind of highlighted one small piece of what I do in this really big tapestry of work. And it as you saw in one of the slides where we list our collaborators, like it takes many, many, many people, all of us working together. So it's a joy to collaborate with you, Mary Jane, and everybody else.
Yeah, it's been fun. It's been a highlight during this otherwise dreary period. And and getting the team that we have working together is I didn't mention, I guess we didn't mention, we've only really done this virtually. We're contemplating or hoping to be able to, some of us get together as we did in San Antonio recently, but perhaps this year at some other meetings that we're at. But it's if online is going to be the answer for the tool, that's the way we've been doing the research. It's been all virtual. So again, thanks so much. And I guess that's about it for now.